Good afternoon. Today we're going to be talking about Chapter 14, which is Neurological and Sensory Disorders. Lots and lots of information in this chapter. For those that don't know, make sure you know your anatomy and physiology. The nervous system, remember, has your two parts. It has the peripheral nervous system and the central nervous system. The neurons is the central component of the nervous system, and myelin is that protective covering that provides insulation where that nerve impulse can jump cell to cell. So for instance, when you catch your finger in the door, it happens here, and that nerve impulse goes up each one of those by that myelin sheath to the brain, where the brain interprets it as, ow, that hurts. The peripheral nervous system has the somatic and voluntary nervous system and the autonomic or involuntary nervous system. The somatic system has two kinds of nerves, which are afferent and efferent. The afferent nerve fibers carry information from those receptors in the body to the brain. The efferent nerve fibers carry information from the brain back down to the body. The autonomic nervous system is responsible for those involuntary nerve actions, such as like my breathing, reflexes, perspiring, digestion, those kinds of things. And the two divisions of the autonomic nervous system are the sympathetic and parasympathetic nervous system. The sympathetic system is responsible for your fight or flight responses, whereas the parasympathetic system is responsible for the rest and recuperation of your body systems. The central nervous system is composed of the brain and spinal cord, and the brain is divided into three main sections. You have the cerebrum, the cerebellum, and the brainstem. The brain, which is I can't speak today. The cerebrum is the largest section of the brain. It's responsible for complex functions such as your actions and thoughts. The cerebrum is divided into two hemispheres and four lobes, and it's separated by the longitudinal fissure and communicates with each other versus the corpus callosum. The four lobes are named for the bones that cover them. The surface of the brain is a layer of gray matter called the cerebral cortex. The cerebral cortex has three types of functional areas. That's the motor areas that control voluntary movement, sensory areas that control conscious awareness of sensation, and association areas that integrate information. Conscious behavior involves the entire cortex. Below the gray matter is a layer of white matter, which is composed of bundles of myelinated nerve cells that carry the nerve impulses to the neurons. Those four hemispheres or lobes of the brain is the frontal, the parietal, the temporal, and the occipital. The frontal is responsible for managing emotions, judgment, impulses, social behavior. And these are important because if your patient has a brain injury or a stroke, wherever that infarct happens to the brain is what kind of symptoms they have. The parietal lobe is responsible for perception and interpretation of touch, pressure, temperature, and pain. The temporal lobe is responsible for perception and recognition of your memories, your speech, your language. The occipital lobes is responsible for processing visual information. Now remember that your hemispheres act in opposite sides of the body. So if I have a stroke here, this side of my body over here, can't find the thing, is what is affected. If I have it on this side, the other side. So wherever you have that infarct, whether it's a traumatic brain injury, whether it's a stroke, whatever the case may be, it's going to affect the opposite side of the body. The cerebellum is a small structure that lies under the cerebrum and serves to coordinate the motor activity. The brain stem is right back here. It's the lower portion of the brain. This is what we really see in like your Chiari malformations that we'll talk about in a little bit. The brainstem connects the spinal cord and houses the connections between the motor and sensory portions of the brain. And it does house 10 out of the 12 pairs of cranial nerves. It controls automatic behaviors such as things that are necessary to survive. It contributes to the regulation of heartbeat and respirations, your ability to sleep, stay awake. When we talk about the cranial nerves, there are 12 pairs. All but the 2 emerge from the brain stem. Remember your different cranial nerves, you know, the shoulder accessory, the occipital, the facial. There are 12 different nerves of those, and you do need to review those. The ventricles are cavities in the brain that produce CSF, or cerebrospinal fluid, and the CSF serves to provide nourishment and cushioning to the brain and spinal cord. The meninges are the system and membranes that make up the covering of the central nervous system and are composed of 3 layers, which is the dura mater, the arachnoid, and the pia mater. The dura mater, which means tough mother, I like that, that's how I can remember it, is that very thick, strong membrane that surrounds the venous system that takes blood from the brain to the heart. The arachnoid has a thin and spidery appearance. I can remember that, like the arachnoid for the spider. It is a loose-fitting sac that serves to help cushion and protect the central nervous system. The pia mater, which is the soft mother, a thin membrane that covers completely all the surfaces of the brain and spinal cord. The spinal cord is protected by the bones of the vertebrae and divided into 4 sections. Remember, you've got your cervical here, and that supplies movement and feeling to the top of the head, base of the skull, neck, muscles, shoulders, elbows, arms, esophagus, heart, coronary arteries, lungs, chest, breast, and diaphragm. So if you have a patient that has a cervical fracture, especially if it severs the brainstem, if it's above that where the diaphragm nerves are, they're not going to be able to breathe. Thoracic, that's your mid-back. It supplies blood to the head, brain, eyes, ears, nose, sinuses, esophagus, heart, lungs, all kinds of good stuff. Uterus, appendix, buttocks, and colon. And then you have your lumbar, which is the low back. This provides the control over the large intestines, buttocks, groin, reproductive organs, colon, upper legs, knees, sciatic nerves. Think about your patients that are older that have the sciatica. That's where this stems from. The sacrum, and that helps regulate the buttocks, reproductive organs, bladder, and that's right at, you get your sacrum and your coccyx right at the bottom. And the coccyx is nerves that control and regulate the rectum. The spinal cord has meninges that has 5 layers. I'm not going to go into that a lot because we're not going to test on it. Just remember that spinal cord, you know, that's what carries those nerve impulses. That has that CSF. Major importance. Your reflexes are involuntary movements that occur in response to a stimulus. They occur at the brainstem or spinal cord level. Deep tendon reflexes occur at the level of the spinal cord. A decreased reflex response usually indicates a problem with the peripheral nervous system. A brisk or exaggerated reflex response indicates a problem with the central nervous system. If we can think about it in class, I will let you check my deep tendon reflexes. I have very exaggerated reflexes due to my multiple sclerosis. So it's kind of interesting to see because, again, that indicates an issue with that central nervous system. Primitive reflexes are controlled by the brainstem, and these are called your survival reflexes or newborn reflexes. They are automatic and stereotypical. They're present at birth and most disappear within the first few months of life. Think about your startle reflex, your fencing reflex. But you do have some primitive reflexes that do stay lifelong, such as blinking. And you can have a patient with a traumatic brain injury later on in life that will have some of these primitive reflexes that return because they have a frontal lobe issue that it no longer suppresses them. Here is all the different reflexes. Remember, they begin during the embryonic period and they continue through adolescence. Most of those do resolve within the first few months of life. You do need to know that. So you do need to know the grasp reflex and when it disappears, the rooting reflex, the startle reflex, the fencing pose, all kinds of different ones. And the reason why it's important to note this is because when you're doing a well child visit and you're checking this child, you need to know if there is a disruption in those. Because if there's a disruption, that typically means that there's something a lot more serious going on. It's important to assess for an intellectual or developmental delay. You know, anytime you're going to do a developmental assessment, you're going to look at fine motor skills, which are like your hand-eye coordination, and that's where you do your finger to their finger, then to your nose, back and forth, or they can put their hands on their legs and go like this. Lots of different things. Then you have your gross motor skills, language, and that's both your receptive and expressive, social skills, adaptive skills, which is like your feeding, your dressing, your ADLs. Any type of developmental delay needs to be charted and told to the provider, and that can be individual milestones. They may have mixed milestones. They may have a global developmental delay in which all the milestones are delayed. Whatever it is, you do need to report that as well as chart that. And the most common one that parents complain about is the development of expressive language. So your neuro assessment is going to be assessing the mental status, behavior, mood, affect, interaction, level of activity, positioning. You know, do they have those reflexes, level of consciousness, orientation to surroundings, checking all 12 of the cranial nerves. However, unless you have something to check their smell, you can't check that one. Motor, or if they're old enough to smell too, that's another thing to think about. But you're also going to check their motor and sensory function, pupil response, coordination, reflexes, cerebellar, and sensory function. You can use that Glasgow Coma scale for the level of consciousness. You always need to check for scoliosis, joint mobility, gait evaluation, Tanner staging. If you remember, we talked about that in the first week or so of class, and then you should have talked about it again in your growth and developmental class. Tanner staging has stages 1 through 4. 1, which is completely non-existent, which is like your 5 or 6 year old child, versus a Tanner 4, which is a complete adult. When you're doing their background, you want to check the prenatal history, details of the mother's pregnancy, including complications of labor and delivery. Most neurological things are congenital, so we want to check for any of that. Birth trauma, postnatal illness. Did they get Zika? We want to know how that child has developed through their childhood. Have they met their milestones appropriately? Have they had any seizures? Have they been exposed to infections and virus? One of the big ones is Epstein-Barr virus. How is the child's birth history, including gestational age, birth weight, and APGAR scores? What's the family history? Do they have a familial history of neurological diseases? What about epilepsy? What about cerebral vascular disorders, myopathy, cerebellar disorders, headaches? Do they have any first degree relatives, which is primary family or immediate family? of diabetes, cancer, hypertension, cardiovascular diseases. Has the child been in an accident, had any major illnesses, had any surgeries? What's the ages when their milestones were achieved? Were they appropriate? Have they had any history of regression? Do the caregivers have any concerns regarding behavior? Do they interact with others appropriately by their age? Do they have any aggression? Do they have any repetitive behaviors? How's their attention? How's their activity level? Social history? Lots and lots of different things to look at. So then on the physical examination, of course, you always need to make sure that you're doing an appropriate measuring of their head. That is extremely important, and it does show you how to do that in your book, but you want to measure at the largest portion of their head, and they do that. Your microcephalopathy, that is a head circumference that is more than 2 standard deviations below what it should be. Macrocephalopathy is more than 2 standard deviations above the norm. You can see muscle tone abnormalities. You can see increased muscle tone in hypertonia, decreased muscle tone in hypotonia, muscle atrophy or wasting. You can see neurocutaneous lesions, such as like in neurofibromatosis. You can see dysmorphic features, such as low-lying ears, and that's where your ears should line up with the corner of your eye. You can see flat noses, abnormal eyelid creases, so such as like you see in your Down syndrome or your fetal alcohol syndrome. Abnormalities in cranial nerves, such as decreased vision or hearing or inability to use the tongue. Do they have any Down syndrome? Diagnosis, you're going to see chromosomal testing, metabolic screening, thyroid function screening, MRIs, dysmorphic features, like I said, sudden loss or regression of skills, traumatic injury. Treatment, you know, we always want to do developmental appropriate discussions. We don't want to give the patient too much information, but we never want to lie to the patient. We want to use a multidisciplinary approach: physical therapy, occupational therapy, speech therapy, play therapy. We want to get a child life specialist involved. Educational services, audiology, because a lot of times these kids have hearing losses. Psychology, think how hard, even if they don't currently have a mental health disorder, think how hard it is on their image if they are not like the rest of the kids around them. Kids can be very, very mean. So we want to be especially on the lookout for bullying, for the child having a low self-esteem, depression, anxiety. And then you can have your organic psychological disorders where you have some differences in the brain. Maybe the chemical hormones are off. So just be aware of that. Spina bifida, that is the picture. You can't see it very good because my picture is over it, but where the spinal column is born on the outside, it is most often right in the area where that picture shows. All of these are neurotube defects that happen in the embryo. They're thought to be caused by folic acid deficiency, which is why it's important that we educate moms to take folic acid. The neurotube typically closes about the 28th day after fertilization. So you got to think, a lot of women don't even know they're pregnant at this time. The two most common are spina bifida or anencephaly, where the brain doesn't develop. And so back to the folic acid, we do recommend that people that are trying to get pregnant or are pregnant taking 400 micrograms of folic acid a day with multivitamins. And very, very important, if somebody takes a medication that prevents patients from absorbing folic acid, such as on medicines, or if it's a medicine for a high risk of a birth defect, such as your anticonvulsants. Some of your autoimmune medicines are especially hard, so we want to make sure that they're doing that. Symptoms of spinal cord or spina bifida, of course, you're going to see that spinal cord on the outside right there. They can have flaccid paralysis of the legs, knees, ankles, and feet. The amount of signs and symptoms that they have and paralysis is dependent on the severity of the defect. You can have malformations that include the vertebrae. You can have some that are just the spinal cord with surrounding structures of the nerve, bone, muscle, and skin. They can have loss of control of the bowel and bladder. You can have cognitive deficits and learning issues. Spina bifida occulta is a section of the spinal vertebrae is malformed and there's complete absence of the bone. The defect is not always visible. Sometimes you can just have right where the cleft of the buttocks or right where the butt crack starts. A lot of times you can just see this little tiny hole. And when I say little tiny, some people can mistake it for a dimple or a little size of a pin. But that tells you that there is spina bifida occulta. They a lot of times have a high increase in dermoid cysts in that area. And it's most often a incidental finding. Meningeal seal, we're not going to go over that too much. One of the big things you do need to know on spina bifida, meningeal seals, anything like that is anytime you have part of that spinal cord that's born on the outside of the body, you have to be extremely careful and protect it. You need to keep it covered. You need to use aseptic technique, and it needs to be covered with a sterile dressing moistened with warm sterile normal saline. So not distilled water, not tap water. It needs to be warm sterile saline. The child should be position prone and laying on an open diaper. These kids almost always have to have surgical correction where they close a protrusion. If there's bladder involvement, you may have to do intermittent catheterization. If there's bowel involvement, you may have to manually evacuate, which is stimulation, such as a finger or an enema. If hydrocephalus exists, they may have to have an external shunt, which we're going to talk about in a little bit. And they may need adaptive equipment such as your wheelchair, your crutches, depending on how severe it is. Lots and lots of interdisciplinary teams to help with this. Chari malformation is kind of one of my favorite things to talk about. And that's because it's so common that most people don't know about it. And that's that picture on the left. The top one is normal and the right one is where they're starting to get a Chari malformation. It is in 4 different stages. One, of course, is the least one, and that's where the brainstem starts poking out of the base of the skull. So you start getting that brainstem that's down in there a little bit in stage 1, and then stage 4 is where it's really down. Again, it can be very severe. This controls their balance. They can get some vertigo, muscle weakness, numbness, vision problems, headaches. They can fall a lot. So if it's a stage 1, they usually just treat symptomatic. And a lot of times stage 2, that's all they do as well. But when you start getting in those stage 3 and stage 4s, they do surgeries where they kind of remove a little piece of the skull and poke it back up in there. Encephalopathy is where the brain does not develop. The child can be missing both portions of the brain and skull. Again, to prevent this is the best case scenario, and that's where mom is taking that folic acid of 400 micrograms. In encephalopathy, a portion of the brain protrudes through an opening in the skull. A lot of times it's right up here, a groove in the middle of the skull. It can be between the forehead and the nose. It can be on the back side of the skull. Some more on the congenital malformations. I'm going to skip over a lot of these other than, most of these are caused by mom ingesting a carcinogen, whether it's a medication, maybe it's some of the pesticides, maybe it's a chemical at work, but a lot of these are known to be caused by that. They can also be caused by genetic infections. They can be caused by regular infections too. For instance, we talk about the measles, which is one of the reasons why we take the MMR. Microcephaly, where the brain is very, very small, or the skull, which is where you see in this picture. A lot of times that's caused by the Zika virus. It can be caused by radiation, maternal drug, and alcohol use. So lots and lots of different things. I do want to point out that the lystinopathy, that is what they cause, that smooth brain. So instead of having those fissures in the brain, it's smooth. And believe it or not, that is extremely bad. These kiddos have severe neuro impairment. Here is hydrocephalus. Hydrocephalus occurs when the CSF collects in the brain and it isn't able to drain out of there. It causes an enlargement of the ventricles, which can cause harmful pressure on the other tissues of the brain. Remember, you have those 4 ventricles that are connected by narrow channels that allow that CSF to drain down and be reabsorbed in the bloodstream. We have 2 different types. We have congenital and we have acquired. Congenital, of course, is where it's blocked at birth. And most often those are found prenatally on the ultrasounds. Acquired occurs at or after birth. Your book talks about communicating versus non-communicating. You don't really need to know a lot of that. What you do need to know is that it is an abnormal amount of CSF in the brain, and it does cause that enlargement of the ventricles. You can see a rapid increase in the head circumference. You can see bulging fontanelles. That's why it's important to always check the fontanelles of babies. Remember, if they're depressed, that can show us if they're dehydrated. But if it's increased, it's very concerning because that's usually increased intracranial pressure. You can see vomiting, lethargy, irritability, a high-pitched shrill cry, seizures, a downward deviation of the eyes called sunsetting. And if you don't know what that is, look it up. And that's basically where the eyes, you're looking down and you can see the whites above the eyes. So almost like a sunsetting. Because if you look at a person's eyes normally, you should not be able to see the whites under their eyes or the whites over their eyes. You should just be able to see that pupil and the whites on the sides. So that sunsetting is where you can see that white above the eye. Pupils can be sluggish in their response. You can see hypertension. You can see apnea, and this apnea is a central apnea, not an obstructive sleep apnea. If it's not corrected and it worsens, we can see some rigidity and severe arching of the back. Assessment, you're going to complete a general physical examination. You're going to check for recent history of seizures, vomiting, sleepiness, irritability. You're going to assess for eyes that constantly gaze downward. You're going to check for an abnormally large head. And these kids are a lot of times treated with a VP shunt, and that's your ventricle peritoneal shunt. And the reason why it's called that is the shunt goes down into the head and it trails down through the neck down to the belly, peritoneal. So it is released there. you guys need to know how to take care of that baby post-op. And one of the big things you need to remember is that baby needs to lay on the opposite side. So if the shunt is here, they're going to lay on this side. If the shunt is here, they're going to lay on this side. You don't want to compress that and take the chance on that clogging up as it's healing. You're going to assess their level of consciousness, encourage bonding. Pre-op, again, you're not going to lie to the child, but then again, you're not going to talk to them over their developmental stage. You're going to provide them a lot of support. Post-operatively, you're going to assess for signs of increased intracranial pressure. You know, how's that fontanelle bulging? Assessment of their pain level and giving the analgesics as indicated. You're going to teach the caregivers how to care for that VP shunt. You're going to monitor this child for signs of shunt failure or infection, such as, and those signs are rapid onset of vomiting, severe headache, irritability, lethargy, and fever. So it's the same exact symptoms of increased intracranial pressure. Because again, if that shunt fails or if it's clogged up or blocked, you're going to have increased intracranial pressure. You're going to monitor the wound site for redness or drainage. Next, we're going to be talking about sleep disorders in kids. There are lots of different disorders. They're very common and they really affect the child's rest. But think about how, as an adult or as a nursing student, you're really tired when you're in school. And it makes it 10 times worse when you don't sleep well. It's hard to focus. So then think of that as a child. If a child, especially if they have ADHD, if they didn't sleep well, then it's gonna affect their ability to have emotional stability, because think about how your emotions when you're really tired are even more hyperactive. Their behavior is going to be hyperactive and it's going to be really difficult for them to concentrate. So it's really important for us to recognize which kids are high risk for sleeping disorders and, you know, intervene. First, we have insomnia. So when we start thinking about sleeping disorders, you know, even whether it's an adult or a kid, we look at two different things. When it comes to insomnia, are they having trouble going to sleep or are they having trouble staying to sleep? Maybe they go to sleep very quickly, but then they wake up in the middle of the night and can't go back to sleep. So those are two different problems, just so that you're aware of. And they typically have two different etiologies. Kids can have excessive sleepiness from this called hypersomnia, but they can also have narcolepsy, which is daytime sleep attacks where you just fall asleep. We see obstructive sleep disorder in kids, which is your obstructive sleep apnea. And obstructive sleep apnea is completely different in a kid than it is an adult. Remember that obstructive sleep apnea is caused by an obstruction in the airway. As an adult, it is excess tissue from obesity or a floppy palate, decreased muscle tone. But in a kid, it is almost always because their tonsils and adenoids are enlarged. And so then when that child falls back asleep, those tonsils just fall back and occlude that airway. As we start seeing the BMI of kids increase and the incidence of obesity, sometimes it may be though because they have a really large tongue or they have the floppy palate, but for the most part it is typically the tonsils and adenoids. Mom and dad may not realize they're pausing or having sleep apnea. You know, we think of the traditional pausing when they're breathing while they're asleep, but if they're having loud snoring, it really is good to, you know, to do a sleep study. But obstructive sleep apnea is the #1 reason for a tonsillectomy and adenoidectomy in kids. And remember, those adenoids are down in that oral pharynx, and it's made up of the same tissue as the tonsils. So when the tonsils are enlarged, the adenoids are enlarged. You also have things called palatine tonsils, which made up the same tissue in that throat. So if all of those are enlarged, it can just cause that sleep apnea. We also see kids, one of the symptoms of sleep apnea that you may not think about is nighttime enuresis, which that means basically nighttime urinating. When our body goes to sleep and it goes deep into REM sleep, our urine output, our brain signals to our kidneys that we need to decrease the urine output. While we're awake, we produce about 30 milliliters of urine. You do not need to know that for Peds. I'm not going to promise that in your med-surg class, but what you do need to know is that when you're awake, your brain signals to your kidneys that you need to produce more urine. Once you go to sleep and get into that deep REM sleep, the brain signals to the kidneys that they need to slow down on producing urine. That's why most people don't get up through the night to urinate, or if they do, it's only once. Well, because the obstructive sleep apnea keeps the child from going into the deep REM sleep because your body wakes itself up trying to get that breath. The brain never signals to those kidneys to slow down on making the urine, so the kid is still producing urine like it's awake. So then, of course, you can have some nighttime bedwetting. You can also see impaired growth. You do need to remember this, that the human growth hormone is released when you're asleep, which is why whenever they do the injections, and we'll talk about that when we get to that chapter, but when you do the medications, you do those at night because that's when you release that growth hormone. However, if a child has obstructive sleep apnea, they're not releasing that, so you start seeing them have impaired growth. You can see them have hypertension just because the kiddo, their body is at stress. And you can see some core pulmonale. You can see some parasomnia, and that's the abnormal group of sleep behaviors with rapid eye movements or non-rapid eye movement, and you start seeing the REM with parasomnia with nightmares, the non-rapid REM parasomnia is sleepwalking, night terrors, nocturnal uresis, and rhythmic movement disorders. And so your treatment is going to really depend on the frequency and their potential for self-harm. And again, these kiddos all should be referred for sleep study, and they may need to see a pulmonologist as well. Remember, your nighttime terrors is awakening in the first third of the night, usually between about midnight and 2 a.m., screaming in fear. They're disoriented, and it's hard for them to get their wits. They just don't understand, so parents are unable to comfort the child. And you have to remember, we're not talking about just toddlers here. These kids can be 7 or 8, and they just are so disoriented, it's hard to do that. It can be triggered by fever, emotional stress, or sleep deprivation. And the next morning, the kid is not going to remember this. It's most common in boys age 5 to 7, but it can happen in all kiddos 3 to 7, ages 3 to 7. Can occur in older kids and adolescents with emotional stress and alcohol intake. Assessment-wise, you're going to see dilated pupils, tachycardia, and some diaphoresis. They may be sleepwalking. They can include different physical activity such as dressing or undressing. I've heard of instances where kiddos have actually unlocked the door, they've went outside. One particular incident was there was a ledge and the child was actually scared of heights, so they would have never done that during the day, but while they were sleepwalking, they actually got up and walked along the edge. It was just a miracle that they did not fall off of that, and the parents' home security camera caught it all. This often occurs in non-REM sleep in stage 3 or 4. It occurs early and nights. It does tend to run in families, and the child looks awake and their eyes are open. However, they may have nonsensical speech, which means it doesn't make sense. However, they can talk to you and you don't realize, if you don't know that child, sometimes you do not realize that they may not be awake. They can act out dreams violently. And we see this in adults with people coming back from war that has severe PTSD. Can be the same way with a child that's been abused, or maybe a traumatic brain injury, or they've had some type of trauma. RLS, restless leg syndrome. This is exactly what it is an adult, but it's a sensory and a motor disorder. The child feels like they just have to move their legs to relieve the discomfort. It typically occurs at bedtime, but it can occur during any period of inactivity, such as at school where they have to sit and they're not moving, prolonged sitting, car rides. We really don't know most of the time what causes them, but we do know it can be related to low iron, diabetes, kidney, or neuro disease. It does typically run in families. Certain medications can increase the risk, such as your medicines for allergies, especially like your first generation antihistamines, like Benadryl, depression meds, and other behavioral disorder medications. Diagnosis is based on the symptoms alone. And treatment includes regular exercise, caffeine reduction, checking iron levels, and eliminating any causative factors such as playing video games, lots of TV watching, if it was the medication, changing the medicine. And those kids are going to have an assessment such as they're going to be checked to make sure their blood sugar is stable, they don't have any GERD, they're not having seizures. You want them to keep a sleep diary. Are they daytime napping? Do they have stressors going on? That can be emotional and physical. How much caffeine are they taking? Any medications that can cause a sleep disorder? Are they overweight or have obesity? And again, all of these, you're going to want that sleep disorder. And you're going to educate people on sleep hygiene. Anybody that complains of poor sleep, you know, our sleep hygiene is the same for kids as it is for adults, but they need to go to bed at the same time each night and get up same time of a morning, even on weekends. The child should only be allowed to sleep in the bed. They should not use any kind of video games, especially, you know, laying in bed watching TikTok. They shouldn't be on their phones. Any kind of electronic device or watching TV, playing video games should really be avoided in bed, as well as within about 3 to 4 hours of sleeping or going to bed. The bedroom should be dark, quiet, and cool. People sleep better when it's cool, even if they're a little bit on the chilly side. If the kid has an alarm clock, turn it away from the bed so they can't see it. Make sure you establish a nightly bedtime routine, such as we're going to brush our teeth, we're going to put on the pajamas, we're going to read a story. And this really helps your brain to know, hey, it's getting close, it's almost time to go to sleep, so that when the child does lay down, it can go to sleep. Sleep aids, such as you hear people taking Benadryl, melatonin, and these really should be avoided in kids. Okay, do you remember this? With microcephaly, the head circumference is more than how many standard deviations blank average? Is it 2? Is it below average, above average? Is it 3? Is it below average or above average? Do you all remember this? The correct answer is A. If you guys remember, microcephalopathy, the head circumference is more than 2 standard deviations below the child's where they should be on their head circumference. Macrocephaly is 2 standard deviations above. Seizure disorders. Sorry for that face. I thought I just deleted my whole PowerPoint that I've recorded. You know, we're not going to spend a lot of time on seizures, but we do need to know some points. Seizure disorders are more common in kids than they are adults, and they're more common in adolescents. And we have to think of, as kids start hitting puberty, the chemicals in their body, the hormones are going crazy. Well, think of all those hormone receptors that you have in your brain. So some of these seizure disorders will start when they start getting close to puberty or into puberty. But we have to remember, seizures themselves are because of a sudden abnormal electrical activity in the brain. A single seizure or convulsion is a symptom of the abnormal electrical activity. Reoccurrent seizures are often diagnostic of epilepsy. We do an EEG, which is electroencephalogram, and that checks their brain waves and can really tell us if it is truly epilepsy, if it's reoccurrent. The different types of seizures and seizures disorders are classified according to the place in their brain where it starts. You know, when we think about seizures, we think of the grand mal seizures, and this is often not the case. These kiddos can have absent seizures, partial brain seizures, which is also called focal seizures, and we'll kind of talk about this. A lot of children and adults experience an aura. An aura is a syndrome that happens, or a feeling before they have the seizure. It can be an unexplained odor. It can be a pain in their head or their limb, and they can last for a few seconds to a few minutes. My son developed epilepsy when he was getting ready to go through puberty. So I think he was about 11 when he started having problems, and he would see crackles or sparkles in his vision before he would have a seizure. So just remember, it's not concrete evidence. Everyone is different, but some people don't have an aura, some people do. Sleep deprivation is the most common trigger. So we really want to teach them sleep hygiene, but this is also why when they do EEGs on kiddos, they are sleep deprived, so they don't let the child sleep the night before, or if they do sleep, it's a very small amount. Other triggers can be stress, alcohol, substance abuse, not taking their medicines. I'm going to kind of skip down through these. They will usually have an MRI because besides the EEG, because they do want to make sure that there's no brain tumor there, and that it is, you know, an electrical issue. When they have that EEG, though, it's very interesting. Like I said, they are sleep deprived. They make the child hyperventilate, so they'll have them, usually they have like a pinwheel, and they have to blow, 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 and the child actually gets to where they feel like they're going to pass out because they're blowing so hard, they're not getting enough oxygen. Well, they do that to put stress on the body, excuse me, because again, stress, whether it's physical stress, which that's physical stress, or emotional stress, can trigger seizures. Remember that we can see febrile seizures, and it's important to identify that. And typically, it's not caused by a fever that goes high and stays high. It's caused by how quickly they get the fever and how quickly it elevates. So for instance, if you've got a kid that one day their fever is 100, the next day it's 101, the next day it's 103, yes, that's concerning for sepsis, but not high risk for a febrile seizure. When you have a kid that is normal and within 30 minutes goes to 103, those are the ones that are more high risk. Doesn't mean they're going to have them, but it is high risk. If a seizure lasts longer than 2 minutes, especially if that includes loss of awareness, parents are taught to administer rectal diazepam or Versed. Versed can be given intranasally, so that's usually the preferred method. The first time I had to give my kid Versed at home, I was freaked out because I was used to being an RN where we were just given Versed for sedation in a GI lab. But they do have the rectal diazepam, which is also called Diastat, or the intranasal Versed. If seizures last longer than 5 minutes, you do want to educate the parents to call 911. Sometimes these lengthy seizures may require IV medications. A prolonged seizure, though, can cause permanent damage. Your nursing interventions is you always want to instruct parents, make sure, or caregivers, make sure the area around them is clear of debris and nothing that's going to hurt them. For instance, if they're, and I'm trying to think of a good example, but maybe they're somewhere that is near a street. You want to move them over a little bit. Any sharp objects, you want to remove those. And if they are vomiting, you want to try to turn them on their side. Don't turn just their head because they are very stiff, they're seizing. But you know, that is if they're vomiting or if their mouth is foaming because they're high risk for aspiration. So make sure and turn them on their side. Just a note, pregnant women are turned on the left side to avoid the compression of the inferior vena cava. And you're going to hear this in your maternal child class a lot. Anytime there's trauma, anytime there's an issue, you always turn mama on her left side. You never put anything in the mouth of a person having seizures. You know, you used to hear of them doing like a tongue depressor to keep the airway open or a bite block. We do not. That is old. We don't do that. We do not want to restrain the child. If there's anything tight around the neck, you want to try to loosen it, like a necklace, or maybe it's a boy and he has a button-up shirt that's really tight, or a tie. Once the seizure's over, the child's going to be very tired and want to sleep, but they can be confused. So you want to comfort them. If it's not a grand mal seizure, they're never going to lose consciousness. So again, the best thing you can do is keep everyone calm. Kids can also have a headache when it's done. Now let's talk a little bit. I'm trying to just read down through these a little bit. Your partial brain seizure, also known as focal seizures. So that means it originates in one part of the brain. It does not go full brain. It is literally one part of the brain. And where the child has symptoms at is really dependent on where the seizure starts in the brain. It's usually very brief and confined to small movements with no or mild loss of awareness. However, if it doesn't stop, it can turn into a secondary full brain seizure where it spreads. So that can be very scary. So I'm going to give you an instance of my son when he developed epilepsy, just to kind of make this hit home. He had the partial brain or focal seizures. So, so when you think about that, we had driven from Missouri to Florida to Destin. It was 12 hours, and we decided because my ex-husband and I, the kids were young, we were going to drive through the night so that they would sleep. Well, my son at the time was, like I said, almost 11, about 2 months shy of his 11th birthday. We drove overnight. Well, he was so excited, he stayed awake in the middle seat and played his little handheld video game. I don't remember which it was. And so he didn't sleep much at all. Got to Florida. We were too early to check into the hotel, so we waited. It was about 5:30 in the morning, and the IHOP opened at 6, so we sat in the car, waited till 6. And I remember specifically the sun was starting to come up because it gets lighter in Florida earlier. The sun was starting to come up, and he told me at that time, he goes, "Mom, the sun is so bright here." He goes, "I can't believe how bright it is." And in my mind, because he was a perfectly healthy child with no medical problems ever, I remember thinking, oh, he's just really excited, and the sun is bright, and we're not used to the sun coming up this early. Well, we proceeded to go into IHOP and sat down at our little booth, and the waiter was very slow, and it wasn't his fault. He had a lot of people to take care of, and he had brought our drinks, and we were getting ready to order. And actually, I think we did place our order. And my son was always goofing off. He's like me. He's a jokester. And when he was sitting at the table, I want to make sure my hands are here, his hand kind of just started, and it was just every once in a while, and he would just kind of jerk. And I didn't pay too much about it. Well, then the next thing, I saw his head do that about, and I'm going to say every probably 45 seconds to a minute. And I said, son, knock it off. We're in a restaurant. You got this arm that occasionally goes, and then this head that occasionally goes. And I just think he's joking around. Again, you have to remember, this is a normal, healthy child that's never had a medical problem. And my daughter, who was 15 at the time, looked at me and she goes, Mom, he's not joking. Something is wrong with him. And then as I'm trying to figure out what's going on, it gets worse to where it's about every 15 to 20 seconds. And I instantly know, oh my gosh, this is a seizure. I've never seen a partial brain seizure before. So we had to try to flag down the gentleman that was the waiter, pay our bill, get out of there, get him to the emergency room. But that is a focal seizure. They just have one side. When you have a grand mal seizure, which, like I said, focal seizures can turn into grand mal seizures. Grand mal seizures are where you think of the traditional seizures, where they're tonic, clonic, shaking. They can not be breathing. They do not have consciousness. They usually are incontinent on themselves. So that can be extremely scary. For your test purposes, you are not going to need to know all these different types of seizures and syndromes. What you do need to know is sleep hygiene, triggers, how to keep, the video games, the stress, the lack of sleep. What's the difference between focal seizures or partial brain seizures and full seizures? And then how to take care of a child while they're having a seizure and post-ictal. That's what you need to know for the test. These are just a couple of other seizures that are different seizures, disorders. The other thing I want you guys to know, besides the focal brain and the full brain seizures, is the absence seizures that kids can have. And that's where they are staring off into space. Sometimes people don't realize that these are seizures and they think the child is just a daydreamer, but it does affect their ability to learn. So, FYI on that. And they are treated with anti-seizure medicine. The absent seizures are called petit mal seizures, but they don't have any movements with it. It literally is just an absence. That's why they call them absent seizures. This does happen mostly in kids. Occasionally, but it is pretty rare, they might have some lip smacking or fluttering eyelids, but not typically. Not typically, that's pretty rare. And, they're absent seizures, usually 30 seconds to a minute. They're quick, but they can happen hundreds of times today. And, when you start thinking of a 15 or 16-year-old that's starting to drive, they can be very dangerous. So, medications, anti-seizure medicines are hard on the body. When we start looking at those, we start looking at rescue medicines for the seizures, such as we talked about with the diazepam and the Versed. Those are just rescue meds when they've been having a prolonged seizure. We start looking at some of the ones that they take on a daily basis, such as your phenobarb, your Keppra, your Topramate, but all of these can build up in the body. So if they're on phenobarb, they're going to happen to have lab levels checked to make sure they're not getting toxic. They all have a lot of side effects of sedation, irritability. They can have some hypotension. Again, think about if you're sedated, your blood pressure drops. A lot of times they will give them some vitamin supplementation because we know that if a child is low on vitamins, it makes those electrical impulses worse. That's true of an adult as well. And one of the new ones that is not on here is magnesium. If you have somebody with a low magnesium level, their electrical impulses can be worse. So we want to get those checked. You guys do need to know the medication classes that is treating, and you do need to know which is the rescue meds, which is the daily meds, and their adverse effects. Syncope is fainting, where they lose a brief loss of consciousness and they fall to the ground because they don't control anything. It is caused by a temporary decrease of blood flow to the brain. Typically, the etiology is blood not circulating. So you can see a vasovagal syncope, which when that blood pressure drops quickly, it reduces that flow to the brain. A lot of times, standing results in a flow of blood to the lower extremities, and that autonomic nervous system tends to act in conjunction with the heart to normalize it. You hear a lot of people getting diagnosed with POTS. It's kind of the new trendy thing, I think, and that's posterior tachycardia syndrome. And that's where people get a rapid heartbeat. So tachycardia, and then fainting when they stand up from it dropping. These kids with POTS do have to be seen by both cardiology and neurology. You can see orthostatic hypotension. So anybody that we think is dehydrated, you're going to do orthostatic blood pressures, and that's where they're laying down. You take their pulse rate and their blood pressure, then sitting up, and then standing up, and they will drop. Heart rate goes up, blood pressure drops, and so then they would be orthostatically positive, but it can cause syncope if there's a huge drop or if it's a quick drop. You can also see it from the cardiac etiology, and that's where we start seeing, because again, decreased blood flow to the brain. So are they having a heart arrhythmia? Are they having a cardiac or carotid blood vessel obstructed for some reason? We don't see a lot of like ischemic heart disease or coronary artery disease in kiddos, but with the incidence of obesity going up, we can. But we can see those heart arrhythmias, heart valve disease, especially if it's congenital. We really talked about that last week. Aortic stenosis. Because again, remember, anytime you see that word stenosis, you mean that's showing narrowing. So if we're not getting blood, that can do that. Carotid stenosis, heart failure. Psychogenic syncope, that's when a person faints in response to anxiety or panic, especially if they have a panic disorder. Metabolic syncope, that's when a person passes out due to hypoglycemia or hyperventilation. If they're hyperventilating, they can definitely, because they're not getting that good gas exchange. Your assessment, you're going to do a good physical examination. You want a detailed history. And sometimes the diagnosis can be made on just by the history alone. An EEG does need to be done to check for seizures or other neuro conditions. Blood tests check for all those metabolic problems. In about 30% of the case, we never know why or what happened. Treatment is aimed at supportive care and then prevention, of course, of future syncope. Headaches, we are seeing more and more headaches and migraines in kiddos. Typically, they can be benign, but there are a couple of disorders that they are not behind. Remember that anybody that ever complains of, oh my gosh, this is the worst headache I've ever had in my life, they need to go have that checked. One of my good friends lost their child. Did not know anything was wrong with him. He was 6. Just came up and said he had this horrendous headache and no history of anything, so no history of headaches. And she did, because he started vomiting, take him to the ER. But unfortunately, by the time she got to the ER, he did have an aneurysm in his brain that ruptured and he passed. So anytime you have a caregiver that reports the worst headache, especially if it's accompanied by any other symptoms, they need to get checked. Kids, we know with migraines and chronic headaches do miss a lot of sports or social activities. This can cause some depression in kiddos. It can cause stress in kiddos, especially if their parents are having to miss work and it's causing them to have a financial issue. Think about you all. If you're missing a day of work a week, not going to be able to keep that job. Or maybe you are able to keep the job, but how are you going to pay your bills? When the kid knows it's their fault, this does put pressure on them. Primary headaches, that's where the headaches occur spontaneously and not because of any health problems or trauma. These are your migraine and your tension headaches. Secondary headaches happen because of something else, such as your infection, your head injuries, the brain tumor. A concussion is a closed head injury in which there's a blow to the head from trauma. It can be car accident, can be sports, can be child abuse. And the child can or may not have loss of consciousness, but after the head injury, they get a headache and changes in their cognitive function. Recovery can take days, weeks, or months. We do want to educate caregivers and child that they have to refrain from any strenuous activity, especially any contact sports that put them at a risk for a second concussion until that first concussion has completely resolved. You think of your kiddos in like Mighty Mite football, they've become very strict about that. Used to, oh, they got a head injury, they got hit in the head, we're going to let them go right back in the game. And now we're pretty strict about that because we realize what that's doing to that child's brain. There is a risk for a fatal condition known as second impact syndrome. And that's where the brain swells rapidly and the person actually dies very quickly if a second concussion occurs before the first concussion resolves. That's why we're pretty strict about that. Chronic sinus disease can cause headaches, problems with blood vessels in the head, such as aneurysms, tumors, diabetes. So, we really want to get a good headache history. Have them keep a journal. Are they getting headaches every time they drink a soda? Or, you want to get as much data as you can. What time of the day is it? Are they having any nausea, vomiting? Did they have any recent injury? Do they have a fever or stiff neck? Think about your infections like your meningitis or encephalitis. A tension headache is feelings of tightness or pressure around the head, usually in the temple area, and most people report it being like a band that somebody's just tightening. This is a steady pain as opposed to a pounding or throbbing pain. I don't know if I agree with that. Most people with tension headaches do say that band is steady, but it does throb. They get mild or moderate pain. But they're not usually associated with nausea, vomiting like you see in your migraines, but they can be sensitive to noise. They typically last 30 minutes to a few hours, but they can last all day. They usually, especially if it's caused by stress, get less during school holidays, so that's one of the big reasons for the headache diary. Maybe a child is going between 2 households, and we notice a lot of headaches when they go to one particular household. Like I said, stress can definitely cause those tension headaches. Migraine headaches are severe and have a lot of severe throbbing, and it's almost always unilateral. Now, they can progress to bilateral, but typically they start one-sided, and then if not treated, go by both sides. They very rarely start both sides. They get worse with exertion. They have sensitivity to light and sound. They get nausea, vomiting with them. Kiddos can have the aura, just like the seizures. They can be sparkles. They can have weird smells or tastes. They can have colored spots in their vision, blurry vision, vertigo, malaise, and these migraines can last a few hours to several days. They do often run in families, and sleep typically will help relieve them. Treatment for kids is usually supportive, and once they get the headache, they treat them. But as we're seeing more and more headaches, we go to preventative treatment. You can have abdominal headaches or abdominal migraines in kids. We don't really know what causes them, but they are more common in girls. And they usually have acute, severe midline abdominal pain. They get nausea, vomiting, they're pale, they don't want to eat, and they usually last 1 hour to 3 days. You can have cyclic vomiting, which is your recurrent vomiting that can last for hours. And if you see kiddos with these cyclic migraines, often we're going to treat them with amitriptyline. Diagnosis is often made by the history, again, that headache diary. They are going to have MRI or CAT scan to make sure there's no brain tumor or anything, aneurysm, anything off in that brain. They will probably have a serum lactate level to exclude a mitochondrial disorder. And treating is supportive care and prevention. Common headache triggers in kids: skipping meals, dehydration, sleep deprivation, stress. So again, trying to prevent these. So we talked about preventative on the cyclic headaches being amitriptyline. For migraines, we can see beta blockers, which is most often propranolol. We can see them use seizure medicines such as Depakote and Topamax. Remember your side effects for your seizure medicines of your sedation, irritability, fatigue, lethargy. We see antidepressants such as the amitriptyline, the nortriptyline, the venlafaxine. And I am not a big fan of venlafaxine in a child. Venlafaxine is not just an SSRI or a serotonin selective reuptake inhibitor. It actually has 2 different medications in it, and it's very hard to get kids off of venlafaxine. Now, if they're having daily migraines, it's preventing their normal ADLs. It's worth it if nothing else works, but I do use it as a last resort. You can see triptan medicines once they have the headaches, such as your sumatriptan or your Imitrex, the Zomig, the Maxalt. We use antiemetics such as your promethazine or phenergan, your Zofran. That's the one I typically use because, again, phenergan can be sedating, and it can really knock them for a loop. We give them acetaminophen and ibuprofen, and then we tell them to go to sleep. All right, let's jump back into this with neurocutaneous disorders. These are disorders of the nerve cells that lead to abnormal growth of tumors. They're caused by an abnormal development of the cells in the embryonic stage. These are characterized by lots and lots of distinctive neurocutaneous lesions. And cutaneous is skin, so that means you're going to be seeing those lesions on the skin. Some of these conditions can be diagnosed at birth, but may not cause problems till later in life. That's particularly true with like the neurofibromatosis. And so going into neurofibromatosis, that's one of the most common neurocutaneous disorders. You get a ton of tumors that grow on those nerve cells. They cause skin changes, bone deformities, eye problems. They can have seizures from lesions on the brain. It is typically genetic, but sometimes people do get it that we're not exactly sure why. But if you have a parent with it, the child does have up to a 50% chance of getting it. In neurofibromatosis, there's type 1 and type 2. Type 1 is the most common in about 90%, and it's also known as Recklinghausen's disease. And the classic sign of it is a child that has skin pigment findings such as café la spots. These are light brown or coffee colored patches that's present at birth and can look like freckles at first, and then they do grow. Axillary freckling in a young child is highly suspicious, and axillary member is right here under the armpit. The lesions increase in size and number during the first few years of life. Kiddos typically diagnosed have at least 6 café la spots that are larger than a ½ inch in diameter. They're flat, they don't cause pain, and these spots do not progress to tumor. These patients can also have what's called LISH, L-I-S-C-H nodules, and these are tiny non-cancerous tumors in the iris of the eye. So, and in some cases, the tumors can develop along the optic nerves and affect vision. Your assessment, you need to do a general good physical examination, a thorough skin examination. You need to document, do they have macules, papules, are they raised, are they flat, do they bleed, do they have skin color changing, how big are they? And you do need to measure those, because when a child comes back in 6 months or 3 months and you think, oh, these could be the same, they may not have changed, you don't know unless you have a clear-cut measure. Diagnosis is based on clinical findings. They do have a baseline MRI because they can get tumor in the brain. Remember, I said it can cause seizures. They also do an MRI of the optic nerve, and that's the nerve that goes from the eye to the brain, because they can have those LISH nodules that can affect vision. They need to have an EEG if there's any concern of seizures. They need to have genetic testing, which are through blood tests. Treatment is focused on managing the symptoms. Sometimes the neurofibromas are surgically removed if they cause pain or if they cause problems with the organs. If they're not, we leave them alone. Seizures can usually be controlled with medicine, and these kiddos are going to need a specialized educational plan if they have learning disabilities. And then again, because this really affects their self-esteem, and you can see depression, you can see anxiety, so you want to get psychological therapy if you start seeing this. Ataxia telangiectasia is a progressive degenerative disease that involves most of the body systems. It is a recessive genetic disease, which means that both parents have to carry the gene but do not have the disorder. It's typically diagnosed at about 2 years of age, and progresses until the child is unable to sit or stand. We see cerebellar degeneration causing ataxia and slurred speech. Most kids require a wheelchair. We see a bunch of telangiectasias, and these are tiny red veins that appear in the corner of the eyes or on the exposed ears and cheeks when the kid is in sunlight. These can crack open and bleed. So when I worked Ears, Nose, and Throat, we would have a lot of these kiddos come in because they would have nosebleeds. The appearance of the veins is a significant symptom in the diagnosis of the disease. They can have disruptions of the immune system. They can have recurrent respiratory infections and pneumonia, and they can, some cancers are very common, particularly leukemia. Your assessment, you need a good general physical examination, a thorough skin examination. You need to definitely check their developmental milestones to see if they are delayed or if they're current. Diagnosis is based on clinical findings. An MRI of the brain should be performed. A blood test to evaluate for genetic markers are also needed. Treatment is focused on managing the symptoms and screening for other comorbidities. And comorbidities means health problems that can be related. A multiple disciplinary approach is definitely needed for this. I'm not going to go over the other neurocutaneous disorders too much on Sturge and Weber. Your book goes into great detail about that. But just remember that Sturge-Weber is of the face, and it's most often the ophthalmic and maxillary divisions of the trigeminal nerve. Remember that trigeminal nerve comes down in front of this ear, I wish you could see me better. And then it has 3 branches. So it's going to come in right here, trigeminal, and then you're going to have a branch that comes down here, a branch that goes over, and then a branch that goes up. And this does affect all 3 of those. Tuberous sclerosis is tumors that grow in the brains, kidneys, hearts, lungs, eyes, and on the skin. Movement disorders in kids, we see 2 main ones, and that's where they have excessive or hyperkinetic movement, or we have diminished or bradykinetic movement. Hyperkinetic movement is the more popular one, or I shouldn't say popular, but the one that's more common. And these kiddos have abnormal, repetitive, and involuntary movements. They can be tics, which are sudden, repetitive, involuntary movements. They can be tremors, and there are different types of tremors, but basically it's where they can't control, their hand is shaking and they can't control it. You can see dystonia, and that's muscle contractions cause twisting movements of the muscle groups. You can see chorea, which is muscle contractions resulting in quick rhythmic movements that resemble dancing movements. The tics are thought to be caused by a disorder in the communication from the brain to the muscles. This is the most common pediatric movement disorder. And for instance, the child doesn't intend to blink their eyes or rapidly clear their throats, but it just happens. That communication from the brain goes to those nerves and muscles, and so they do it even though they don't want to. You can have vocal tics, and you can even have things like chronic sniffling, clearing of the throat, grunting, squeaking, humming, so all kinds of different things. You can see complex vocal tics, which are repetition of words and syllables. You can have, they can shout obscenities. You've probably seen some of those on TikTok. And the bad thing is complex motor and vocal tics are often mistakenly thought to be voluntary, but the child is unable to control them. So this can be very upsetting to both the family, the child. It can cause anxiety. It can cause depression. So you really want to make sure that you have psychology involved in this child's care. Parents often assume that the child may have Tourette's when the child may not. They could have just a transient tic of childhood. And the distinction between Tourette's and the transient tic is noted by the length of time the tic has been present and the type of tic. Motor or vocal tics are pretty typical that they last for several months, but not longer than 1 month. Tourette syndrome is a disorder of complex motor and vocal tics that have been present for more than 1 year and begin before the child's 18th birthday. It is possible for motor tics to become chronic, whereas vocal tics typically do not. Those typically do resolve. Tics usually come on before about the age of 10, with the most common being about 6 to 7 years of age. And the most common motor tic is eye blinking. However, you can see lots of different ones. The most common vocal tic is sniffling or clearing the throat, and it's often misdiagnosed as an allergy manifestation. Tics may worsen at around age 12 and usually disappear completely by age 18. So you do wonder if some of those hormone changes in the body from puberty may affect that. Tics do worsen with anxiety, and they can be a secondary symptom as a result of infections, particularly strep, which we see a lot in kids. They can be a common side effect of neurostimulants such as Ritalin or Adderall. For ADHD, they can be developmental. We do know that genetic disorders such as Tourette's is familial. They can be caused by neurocutaneous disorders, degenerative disorders, strokes, head trauma. Then we have bradykinetic movements, and these are less common, and these are slow, rigid movements, such as like your older adult with Parkinson's. Ataxia and spasticity are classified as motor dysfunctions, not motion disorders. Assessment-wise, you want to do a good general physical examination. You want to know, anytime you're looking at a movement disorder, what's the frequency? What's the character? Is the environment causing it, such as like a foreign body in the eye? Can the movement be suppressed? The diagnosis is based on clinical findings and histories of tics. And most kids learn to manage the tic on their own. And they really try to not focus on the behavior, especially by the caregivers and teachers. Medications to suppress the tic can be considered if the tic is emotionally distressing to the child. And you always need to screen for other comorbidities. Pediatric stroke or cerebrovascular accidents are common in adults, but do occur in kids in utero during or shortly after birth as a result of the trauma or illness. Neonatal hemorrhage are unfortunately common in premature babies because of the immature blood vessels and how fragile they are. Malformations of brain structures or blood vessels are often the cause of strokes as well in young kids. Infections or illnesses such as meningitis, encephalitis, sickle cell can cause strokes. You can see mild effects, moderate effects, or they can be severe. Exam, you're going to do a thorough examination with vigilance on the part, do they have any weakness on either side? How's their facial? Is there one side that's drooping? If they're old enough to stick their tongue out, do they have one side of the tongue? You're going to want to check all of their cranial nerves. Diagnosis is made based on the areas of bleeding in the brain, verified by CT or MRI. So, meningitis is an inflammation of the meninges, where the connective tissues that cover the brain and spinal cord is caused by either bacteria, viruses, or funguses that's in their cerebrospinal fluid. This is why we do a spinal tap to check the spinal cord or CSF. Viral is usually supportive care. Bacteria is extremely contagious, so we're going to have those on precautions. And prognosis really depends on how quickly care is initiated. This can be a precursor to encephalitis, which is the actual acute inflammation of the brain. You can see brain abscesses. Symptoms of meningitis are severe headache, sore or stiff neck, kerning sign, and you guys need to know that. So when the child is laying on her back, flex the hips. If I can do this right, they're laying on their back. It's hard because I'm mirrored in my little video here. But then you pull their legs up, and pain will often prevent that child from extending from the knee if it's positive. Brudzinski sign, which is one that I use the most, is when you have them laying flat, if you go to flex them up, then they automatically flex that neck, or vice versa. If you have them laying flat and you move their neck up, they automatically flex up the legs. They also can have sudden high fevers, hypothermia, photosensitivity, nausea, vomiting, and bulging fontanelles because of that increased intracranial pressure. They can have altered mental status, irritability, sluggishness, sleepiness, and they can have a rash. But again, I'm going to put in this thing. You guys do need to know what the kernings and the Brudzinski sign are for your test and which one is which. Diagnosis is based on symptoms and lab data. A CBC is going to show elevation in the white cell count, the lumbar puncture or spinal tap. We'll check that CSF fluid. They typically do have a presence of protein as well as white blood cells, and these are cultured to look for the specific agent because, again, it can be caused by different bacteria, different viruses, fungus, and you want to know exactly what you're treating. The most common ones in babies is group B strep and E. coli, and if you remember, mama has strep on her skin a lot of times, and so when they go through the birth canal, they can get that, and if they have any openings which they probably do, in their skins, they can get it. Older kids and adolescents typically get it from strep pneumo, Neisseria meningitidis, and Haemophilus influenza type B. You do need to know how to help that child do a lumbar puncture. So again, you're going to speak to them on their level. You're not going to lie, but you're not going to give them more information than they need either. Don't speak above them. Remember that child is going to be in a knee to chest position because they want to round that spine as much as possible so that the provider can feel the vertebrae and where they need to go. You do, as a nurse, need to be alert to respiratory compromise. Occasionally, they will put the kid in a side-lying position, but they try not to. Just because they want those vertebrae to stick out as much as possible. And they can do, if a child is unable to do the knee to chest, they can hunker over like a table if it's a child. But you want to try to get that spine bent as much as possible. After it's been completed, you're going to put a dry dressing on the puncture site, and that child needs to remain flat for up to 24 hours and can be well hydrated. The more fluids they drink, the better, because you're wanting that body to replace that CSF. You're going to check the puncture sites for signs and symptoms of leakage or hematoma formation. You're going to monitor the vital signs and the neuro status at least every 4 hours for 24 hours. Very, very, very important for that child to lay flat, because otherwise they can have a CSF leak, or and this can cause severe headaches and very miserable. And sometimes they do have to go in and have a blood patch if they have a severe spinal a CSF leak. Treatment of meningitis, they usually have broad spectrum antibiotics until the culture comes back. Supportive care of the child and the caregivers are very important. You do need to be alert to rapid deterioration. These kids can go downhill very, very quick. And often when they start going downhill, the signs are very subtle. So it's important that you're alert and monitoring this child. They are going to be on airborne or droplet precautions. They're going to have hearing loss. They can have learning problems, seizures. They can have developmental delays. And it is fatal if untreated. And even with treatment, about 5 to 20% die. So if you think of 1/5 of the children that get this could die and probably will die, is very, very concerning. You can have lasting effects after the child gets over it. It can cause permanent neurological complications and developmental delays. Viral meningitis is rarely fatal and usually resolves with antiviral medicines. Fungal meningitis, which is caused by fungus, obviously, can be fatal without treatment. And the bad thing about this is antifungal treatment in kids is dangerous itself. So, of course, we always look at risk versus benefits. Protozoa or parasitic infections can be treated with specific medicines, such as like your anti-malaria drugs, which is like your Plaquenil, and some antibiotics. There are vaccines for some type of bacterial meningitis. So right now, that's why they take the Hib, and that's the Haemophilus influenza type B, the pneumococcal, and the meningococcal vaccines. It's extremely important because, like I said, even with treatment, 1/5 of these kids die. So 20 out of 100. So it can be very, very scary. Anytime, your book calls this a critical component, but anytime you have an infant or a child with fever and lethargy and they are very, very ill, meningitis should always be suspected and be worked up. Again, because it can have such devastating complications. Acute flaccid myelitis, that's a neuro condition by sudden onset of limb weakness, loss of muscle tone, and loss of deep tendon reflexes. There's been several high-profile cases in the news of this where the parents they actually, arrested them and cited that they were abusing their child when it wasn't. The child actually had this. So you have to be definitely on lookout. These kids can have respiratory failure. They can have slurred speech, difficulty swallowing. The cases of this is increasing, just so that you guys know. We think it's related to a viral infection such as enterovirus, adenovirus, West Nile virus, but we really don't know. And there's not any specific treatment other than supportive care and therapies. Encephalitis, you guys do need to know that. That's an acute inflammation of the brain related to viral and bacterial infections, herpes simplex virus, or West Nile virus. The ones that I've seen across my career that are the most are probably the herpes simplex. We need to remember that both type 1 or type 2 herpes simplex can cause this. But basically, it causes the brain to swell and can result in meningitis. Symptoms are very similar to meningitis and can last for a few days to a few weeks. The main symptom is altered mental status, which is confusion, irritability, altered level of consciousness, hallucinations. Their speech may be different. They may have labile emotions, which means they just are not reactive. And they can be mild to severe. Symptoms of encephalitis in babies are irritability, poor feeding, bulging nails, vomiting, and body stiffness. Diagnosis is made by MRI and CT scan. They do blood, urine, stool, and sputum cultures trying to identify the agent so that they can appropriately treat it. They, a lot of times, will also do a lumbar puncture. Treatment are high-dose corticosteroids to reduce that inflammation. Infections are treated with antibiotics, antivirals, or antifungals. If the child has fever, seizures, you're going to treat those as well. And a lot of times these kids are on a ventilator. Post-encephalitis treatment includes physical, occupational, and speech therapy. Zika virus. This is a big one. This is our picture here. Zika virus exposure in pregnant women can be devastating in the developing infant. The baby in the picture has microencephalopathy. Remember, that's where the head is 2 standard deviations below the normal circumference. The Zika virus is transmitted through mosquito bites. And symptoms in the mom can include fever, rash, joint pain, and red eyes, but some people are asymptomatic. We do recommend that pregnant women not travel to countries where mosquitoes and Zika is prevalent. Congenital Zika, when the baby is born, if they get it, is the severe microencephaly, which the skull has partially collapsed, decreased brain tissue with a specific pattern of brain damage, including subcortical calcifications, damage to the back of the eye, including macular scarring and focal pigmentary retinal modeling, congenital contractures such as clubfoot, or arthrogryposis, which is a condition in which the infant is born with multiple joint contractures, hypertonia, restricting body movement. And the problem is there's no treatment other than supportive care. So these kids have a horrible outlook or prognosis. Cerebral palsy, I absolutely hate. This is any neuromuscular disorder is a cause of muscular weakness and abnormal tone. They're based on the neuromuscular system that's affected. The most common is cerebral palsy, and it affects motor development. It can be mild with abnormal tone and weakness in one extremity, or severe. The child can have intellectual capabilities, but the whole reason I hate cerebral palsy, it is completely avoidable. Cerebral palsy is a result of damage to the brain before, during, or after the child is born. If the damage occurs before or during birth, it is called congenital. If it occurs afterwards because of injury or illness, it is called acquired. Kids with cerebral palsy have altered sensation, cognitive, communication, perception, or behavior, and they a lot of times do have seizure disorders. Types of cerebral palsy are spastic, and that's the most common. You can have spastic diplegia or diparesis, and that's where stiffness in the legs with difficulty walking, and often their legs will have a scissor gait because they can't bend the knees or the hips or the feet, so it's a scissor. Spastic hemiplegia or hemiparesis is stiffness on one side of the body, usually in the arm more than the leg. You can have spastic quadriplegia or quadriparesis, and that's all 4 limbs. And there's a bunch of other ones that you do not need to know. It's good to read them, but I shouldn't say you don't need to know. You do need to know them, you just don't need to know for the test. Screening for cerebral palsy is any infant and young child not meeting developmental milestones should be screened. Infants and young children who've had an accidental or non-accidental trauma or central nervous system infection should be screened. Cerebral palsy has no cure. Treatment is aimed at early intervention in aggressive institution of physical, occupational, speech, physical therapy, and educational therapy. Physical therapy is designed to maintain mobility and range of motion. Occupational therapy will help with ADL. Speech therapy is establishment, maintenance, and communication and swallowing. The medications used to be treated for cerebral palsy is spasticity, seizures, constipation, urinary tract infections, and pain, and these are all symptomatically. Treatment is lifelong to reduce disability and maximize a child's potential for independent functioning. And I hate this because we often see this in traumatic bursts where the brain just does not get the oxygen that it needs. Muscular dystrophy, you guys may remember the different telethons on TV that are trying to raise money. It is a group of genetic disorders that results in muscular weakness and a decrease in muscle tone over time. It's caused by the X chromosome because a protein dystrophin is produced by the short arm and there's a gene mutation. It's characterized by muscle weakness. It affects the proximal muscles first and then later affects the distal muscles, which is abnormal. Most of the time we see distally that comes proximal. So if you don't know what proximal and distal is, you guys do need to look that up because those are terms in nursing you need to know. But when you look at your legs, proximal means close, distal means the furthest away. So in my mind, I try to remember that distal is close to the word distant. So when you think of the leg, your proximal is going to be the muscles up by your thigh and your hip, and distal is going to be those muscles down by your foot, ankle, calf. So it's saying that these muscle weaknesses are going to start in those large muscles and then work their way out to the extremities. The child, often has difficulty jumping, running, and walking, and it's usually diagnosed before age of 6 years, and it's an X-linked recessive inheritance. It's a leading cause of rapid disability. These kids can have major heart issues because of that muscle of the heart, so they get cardiomyopathy, and death usually occurs in their 30s, and that's caused by progressive respiratory or cardiac failure. A classic finding in these kids are Gower's sign, and that's when a child is in a squatting position and they must use their hands and arms to walk up their body, pushing up as they go. So if they're squatted down, they don't just stand up. They have to use their arms and walk up their body to stand up. And this results from that weakness in the proximal muscles, which are your hips and thighs. We're going to skip down a little bit now on myasthenia gravis, and it's an autoimmune disorder where antibodies block acetylcholine receptors at the neuromuscular junction. Remember, your autoimmune disorders is where your body recognizes something somewhere that as foreign that should not be, so your body starts working against that. So in myasthenia gravis, this is where the antibodies actually block those acetylcholine receptors. And this is the site where the neuron causes the muscles to react. So it affects the voluntary muscles in the eyes, mouth, throat, and extremities. There are 3 different types: congenital, transient, and transient's when a woman with myasthenia gravis gives birth. And so the baby has symptoms of it resulting from those antibodies crossing over to the placenta. Again, your congenitals are born with it. And then there's juvenile, which is the most common in females, particularly Caucasian individuals. But they get it in adolescence, and it's a lifelong condition. Your assessments are the patient usually has predominantly weakness and fatigue. Often people are unable to keep their eyelids raised and develop a condition called ptosis or drooping eyelids. Again, ptosis is a word you guys may not know, but you do need to know it for nursing anytime you work in healthcare. But ptosis is drooping eyelids. Mouth and throat muscles are weakened, affecting the ability to smile and drink liquids. Swallowing becomes very difficult. Parents often will report the child looks tired or sad, and that may be because of the facial features. They're starting to get the drooping eyelids and the inability to smile. So they do a blood test to evaluate the serum acetylcholine receptor antibodies. They do an EMG to look at the muscle activity in the nerves in those muscles. They may do a tensilon test. Medications are often aminoglycosides, procainamide, quinine, Keurig, sertraline, some of the calcium channel blockers and beta blockers. Your calcium channel blockers, remember, are blood pressures as well as beta blockers. Treatment is aimed at supportive care. Cholinesterase inhibitors may be used, and these act to prevent the acetylcholine receptor from being blocked or broken down, so it allows it to be a neurotransmitter. Immunosuppressants can be used because remember, anything autoimmune, your body's fighting against itself, so it helps suppress that. And sometimes they do have to have a surgical procedure to remove the thymus gland. If you guys don't remember from A&P, your thymus gland works to provide T cells. So if you remove that thymus gland, that's going to help not produce so many T cells. However, be aware, thymus loses much of its function after adolescence. So typically, if they're going to have the thymus gland removed, it's usually done in adulthood. Spinal muscle atrophy, we're going to hit that just very quickly. It is a recessive genetic disorder. It results in wasting and weakness of voluntary muscles. It is a degenerative disorder of the anterior horn cells. It is the second most common neuromuscular disorder in kids, and initial findings is often proximal lower extremity weakness. And that's all we're really going to say about that. Guillain-Barré, it is an active inflammatory demyelinating polyneuropathy that affects the peripheral nervous system. If you guys remember, you can't give the flu shot if a patient has a history of Guillain-Barré. But this condition causes neuropathy in which the peripheral nerves are damaged. It can be inherited as a result of a metabolic or endocrine disorder like your diabetes, exposures to chemicals, or medicines like chemotherapy, inflammation, vitamin deficiencies, and trauma. And sometimes we don't know the cause. Demyelating, if you remember, we kind of talked about that. That means a protective myelin covering those nerve cells is eroded. It breaks down, so that nerve impulse is not able to jump from nerve cell to nerve cell. The hallmark of Guillain-Barré is ascending paralysis, in which weakness occurs distally in the lower limbs and spreads to the upper extremities. So distally, it's going to start in those feet and work its way up, going all the way to the upper extremities and torso. Symptoms include decreased sensation, pain, tingling, problems with balance, weakness in the extremities, and it can lead to conditions such as cardiac arrhythmias, respiratory issues, inability to perspire, problems with food absorption, constipation, bladder dysfunction. They will often have a complete loss of deep tendon reflexes, and this condition can be severe and affect the child's ability to breathe. It can be fatal if their pulmonary system is compromised. Your exam, you're going to do a thorough history. You're going to do deep tendon reflexes. Diagnosis is made on symptoms and the diagnostic test. They're going to have an EMG to test those nerves. They're going to have a nerve conduction velocity as well, and that measures the speed of the electrical signals traveling through the nerve. They're going to have a lumbar puncture. Treatment is aimed at supportive care. They can do a plasmapheresis, in which the plasma is removed from the blood cells, then the blood cells are returned to the patient. This is thought to remove the autoantibodies from the blood and reduces the severity and duration. IV immunoglobulins can be given to fight it, and any immunization should be delayed for 8 months. Most patients recover fully, but the case of disease is very slow. And this is one of the things, like I said, when you go to get the flu vaccine, you ask if they've ever had. Traumatic brain injuries, this is where the child can damage brain tissue and its surrounding structure, including the skull, but you may not always have a skull fracture. Injury can be mild to severe and have long-term devastating consequences. A TBI results from acceleration to deceleration or rotational forces. So acceleration, deceleration means go, stop. I apologize, guys. My allergies are bad this morning. Injuries can be open, which is focal, or closed, which is multifocal. Effects are related to the forces involved and the impact of the injury with the connections of the brain. We often see these in falls, sports-related injuries, car accidents, and abuse. Mild trauma to the head, a concussion, may or may not include loss of consciousness. It is defined by a Glasgow Coma scale of 14 or 15 on exam. And remember, your Glasgow Coma scale is going to look at eye-opening, motor response, and verbal response. They're going to have a closed head injury, no physical evidence of a skull fracture, and symptoms may not appear until days or weeks afterwards. Physically, their symptoms may be headache, vomiting, balance disturbance, vertigo, photo and phonosensitivity. That means they're sensitive to light and sound, and double vision. They can be irritable, nervous, anxiety. They can be confused, lack of concentration, forgetful, memory loss. They can be very drowsy, or they could have lack of sleep. You're going to want to do a thorough history of the nature of the injury, including height of the fall, body part affected, forces and circumstances behind the injury, loss of consciousness, memory, inappropriate behavior, presence of vomiting, headache, and vision changes. Your examination is going to be physical, emotional, cognitive, and sleep symptoms, but also an examination for other injuries, including the neck, abdomen, and bone. You do need to check all the cranial nerves. You do need to check for periorbital hemorrhage, and periorbital hemorrhage are known as raccoon eyes because it's right here where a little mouse would go. You want to look for skin discoloration and bruising behind the ear here, which is called battle sign. You want to check for blood behind the eardrum, and so when you look at that eardrum, it's going to be, you can tell there's blood behind it. blood behind it looks completely different than an infection. You want to monitor for persistent vomiting and seizures. These are immediate emergency. They need to be seen immediately. The other few of those emergent signs and symptoms are bleeding from the ear or nose, loss of consciousness, and amnesia. What are clonic movements? Let me go back one other step though. Anytime a child has a head injury, if their story of the mechanism of the injury or what happened does not match, it needs to be reported immediately for possible child abuse. Remember, it is not up to you to determine if child abuse happened or not. It's up to you to report any unusual circumstances or concerns. It is up to the child abuse investigators to figure out if that's child abuse or not. What are clonic movements? Is it sustained rigid postures, bilateral rhythmic jerking, muscle contractions causing twisting movements, muscle contractions resulting in rhythmic movements? They are clonic movements, involve a bilateral rhythmic jerking of the extremities. So guys, in this chapter and for your test, you really need to know the anatomy and physiology, neurological development and how to check the neurological exam, intellectual developmental delay, congenital abnormalities, malformations, hydrocephalus, sleep disorders, seizure disorders. So it was a big chapter. We will do a test review and we're going to do some activities in class. If I can be of any other assistance or answer any additional questions, please don't hesitate to let me know. You all have a great day. Thank you.